of 86, he developed unrelenting headaches and a progressive stroke-like syndrome. This was his CAT scan early in his illness, which was relatively normal at that time. He had a very extensive workup at numerous medical centers, including some of the finest in the country. Because serologic tests for Lyme disease were negative, the diagnosis was discarded, and he was not treated. He went on to have a very, very devastating neurologic course. Finally, in 1988, at the insistence of his wife, because she knew that he had had the rash, he had repeated serologic testing, which came back reactive for Lyme disease through Stony Brook. He was treated with a 2-week course of ceftriaxone. The physician taking care of the patient in a rather patronizing way told the wife that he was quite sure that this must be a false positive Lyme titer, and besides, there wasn't really very much that could be done for the patient. This is another CAT scan at that time. When he came under my care, his MRI looked like this, where he had severe neurologic injury with hydrocephalus. Spinal fluid at that time was abnormal, and he had varying serologic results, one borderline and one positive Lyme serology. Again, we're going to have to really rush through this. This was Pat Coyle's research assay on his spinal fluid, which was only run after I had already been involved in taking care of him for quite some time, but it showed that, at least in her assay, it was positive for OspA antigen at a level 3 or 4 times what she considered her positive cutoff. Let me go back. He was treated with ceftriaxone for about a month, and then several months of pulsefataxine. In view of his limited potential for recovery, I did not personally think that it was justifiable to treat him with daily ceftriaxone for a long period of time. He did improve modestly, and the visiting nurses helped to document his improvement in his status. Eventually he died, and he did come to autopsy. And this is what his brain tissue looked like grossly. And this is the floor of the 4th ventricle with a granular ependymitis. And the microscopic showed a luxuriant, rip-roaring meningoencephalomyelitis that Paul Duray said that neither he nor anyone at the Brigham had ever seen anything like it. And this involved all levels of the neuraxis, including the spinal cord. This is the floor of the 4th ventricle showing the ependymitis. Curiously, there was a giant cell giant cells were detectable in the brain. We were not able to visualize spirochetes. Of course, the man had been very intensively treated. Although all tissues had not been examined, I still have tissues on this case, which I was able to get from the coroner. I'm going to try to get some of these tissues to Paul Duray to study in greater depth. And also, I would invite anyone here who has expertise in histopathology who would like to look at them, that I could make some of these tissues available. One of the lessons of this case is that I think that it is a false teaching that late Lyme disease is almost invariably seropositive. And okay, now this was his autopsy spinal fluid tested through Pat Coyle's lab, and let's see. It showed that he had, in the spinal fluid, Lyme-specific immune complexes at a level 10 times her positive cutoff. And also, let's see, let me see, I don't know if it's showing up on here, but he also had, even in the terminal spinal fluid after treatment, he still was OspA positive. I guess I'm going to have to stop. Well, I'm going to have to run through very quickly. Case of another woman who had a tick bite, a rash that was later diagnosed as granuloma annulare, and who went on to develop serious ocular involvement with uveitis, retinal vasculitis, pars planitis, and anterior and posterior uveitis. Well, I wish I could show you these cases. They include this case, which was seronegative for 13 years, finally seroconverted, who had a lymphocytic pleocytosis and many other abnormal CSF parameters that progressively responded to an 8-month course of cefotaxime. And the last case, which I guess I'm not going to have a chance to show, is a patient who absolutely met clinical criteria for multiple sclerosis in CSF and clinically, who had epidemiologic risk for exposure to Lyme disease, but in whom we had absolutely zero proof from any laboratory studies of Lyme disease, who did respond clinically and also with dramatic improvement and practical normalization of very abnormal CSF to a 4-month course of cefotaxime. I guess there's going to be no alternative for me but to have to put these cases together and publish them in a peer-reviewed journal. I'm sorry that they're so clipped and I couldn't really present them as I would have liked to. Thank you.
So the next speakers are Dr. Boris Garner and Dr. Catto.
The microphone is not on.
I got a mic? All right. Thank you. Good afternoon. I'd like to thank and give a great deal of credit to both the Lyme Foundation and the BC Borreliosis Society because I think this is a wonderful conference. It's well run. It's a terrific program, and I think you all deserve a lot of credit. Okay. We have a dead machine here? Okay. All right. What I want to speak about today was how I approached the management of somebody with late chronic disseminated Lyme disease, perhaps as you would see in the setting of someone, in my case, who's often serves as a referral person for patients who had been treated before and who did not respond well. I'm not going to spend time on diagnosis other than to go through the steps the thought process that I go through to try and find out what's going on in the patient and the best steps to take, in my mind, for getting the patient well. Obviously, management of a late case of Lyme disease, and I call late case having chronic symptoms for 1 year or longer. And the reason why I say that is years ago I did a statistical analysis of my patients who, at some threshold in their course of their Lyme, they seem to become much worse and much less responsive to treatment. And that statistically came out to be about 12 months. So for simple sake, let's just say a patient has had Lyme for at least a year with chronic multi-system involvement. The management is difficult. We don't have enough information. Bacteriology is lacking. We don't know that much about pathophysiology in the living human host. Host factors play a very large role, and I'm sure we don't know enough about that. I'm very positive of that. As you now know, and probably have known, we don't have definitive tests to prove that Borrelia burgdorferi is or is not present. And even if we find Borrelia burgdorferi, are those symptoms from the Borrelia, or is there some other problem going on? We don't know how to predict therapy. How much medication will be required? After treatment, will the patient recover? Will there be some permanent damage? How much of the complaint that the patient is presenting with already represents permanent damage and further treatment will be futile? We have no tests to follow the progress of the patient or the treatment. We have no tests for cure. So how do we approach such a vague problem which can be severe? Well, anytime you have such a problem, you must get back to the simple basics of the problem. Simple basic one, confirm the diagnosis. As you know, testing is not 100%, so you have to go through the whole entire history, the evolution of illness, perhaps vector exposure, objective tests for Lyme disease. I like to do antibody and antigen testing in these more difficult cases and see whether the results make sense in light of the clinical setting. Lyme often becomes a diagnosis of exclusion as well, so therefore the workup very often involves, if not always involves, fairly detailed evaluation looking for like-presenting illnesses or concurrent infections or other problems. So a decision tree comes up. All right, let's assume the patient has been pretty confidently diagnosed as having Lyme disease. Okay? Was the patient properly treated? If in your mind the patient was not, then you retreat the patient perhaps more aggressively. If the patient was treated aggressively and still is ill, then you have to move to a second step. So step number one is assessing treatment. Well, again, we can go spend hours on each slide here, but there are many mechanisms now in the literature, and these are all literature citations, of different mechanisms by where the organism can evade the defenses of the host and the effects of antibiotics. Pharmacology is one point I would like to emphasize during the talk today also. We know that there are very poor correlations in our objective testing, laboratory testing, and bench testing of the spirochete and the illness. For example, we know that some in vitro results on antibiotic susceptibility have no bearing on animal studies. Likewise, we find animal results often don't correlate well with human results. Often what you read and think is true about medication turns out not to be. One perfect example is the use of doxycycline, and I'll show data on this shortly. You can read in pharmacologic textbooks that doxycycline is very well absorbed, and intravenous use of doxycycline is not usually necessary. Well, I'll show you some data that shows that's completely false. Not enough emphasis, I'm convinced, not enough emphasis has been placed on documenting blood and spinal fluid levels, and at least trying to achieve what would be a reasonable level. Time killing curves were shown years ago by Ben Luft to be vitally important. Antibiotics have to be continued, at least certain classes of them, for a fairly long period of time at bactericidal levels to be able to kill the spirochete. The question of dormancy and latency comes up. If we have a non-dividing, non-growing spirochete, will the antibiotics kill such a latent spirochete? Perhaps not. Another problem that we have trouble addressing and doesn't make sense is the new use of bicillin, benzathine, penicillin, in Lyme disease. We're using a medication in extremely small doses for a long period of time. The medication is not supposed to cross the blood-brain barrier, yet we're finding terrific results, and we're finding clearing of what appear to be central nervous system involvement. I'd like to talk about blood levels. This is a very simple graphic representation of measurements of blood levels in my patients on doxycycline orally. Now, you can get very involved in the minutiae of the slide, but I just want to tell you some values. These are patients who are receiving doxycycline 100 milligrams 3 times a day, very carefully instructed on how to take doxycycline properly to make sure the absorption can be optimized. You can find the peak blood level varies from as low as 2 to as high as 12.5, and these are matched patients in terms of height, weight, and age. You can find the troughs going from 1 to as high as 8.6. The average peak is 5.7, average trough is 3.6. So right away you see there's such a tremendous variation. I think it's inappropriate to say, let's treat Lyme disease with X milligram of doxycycline because that should work. I really, really think if you have a chronic patient in whom you're contemplating long-term therapy, or at least extended therapy, that you document levels to see where you are. Here's the information on intravenous doxycycline, also 300 milligrams daily. The peak level ranged from 4 to 17.5, the trough from 3 to 7.2. Here the mean peak was 10.5, as opposed to the mean peak of oral of 5.7. It's nearly double on the average, yet the peak here of 17.5 is nearly 9 times higher than some of the peaks on the oral. So here we have such a wide variation, not only of individual levels on the same patient and different routes of administration, because many of these are crossover patients, but also we see such a big discrepancy between oral and IV administration. Just to round out the basic concept, same thing was done with oral amoxicillin. And this goes back to what Dr. Coyle had said earlier. Can we find an oral regimen that might work in place of intravenous for central nervous system Lyme disease? The literature speaks of using amoxicillin 6,000 milligrams a day for treating neurosyphilis. These graphs represent patients treated with amoxicillin 6,000 milligrams a day. The peak levels range from 0.6 micrograms to as high as 17.8. The trough ranges from undetectable, 0.0, to 4.0. So again, even at very high oral doses, you see a tremendously wide variation. So the point I'd like to make from these slides is you have to take blood levels when you're using oral medication to know where to go. This is a busy slide. I don't have the time to go through it, and many of you have seen this before. But again, if you can compare peak serum levels of the antibiotics, peak spinal fluid levels, and the laboratory assessment of MBCs, look, for example, at the third-generation cephalosporins intravenously. We have a very, very good MBC, much higher blood levels than, for example, comparing doxycycline or amoxicillin. Doxycycline, the peaks versus the MBCs, a matter of a few orders of magnitude, whereas if you compare numbers, you can see intravenous antibiotics potentially, and if you believe these numbers, have a 1 to 10,000 time advantage in terms of efficacy over the oral antibiotics. And the second point, of course, is duration of treatment. I really don't think it's a question any longer that a longer duration of treatment than 2 to 4 weeks is necessary to treat the chronic Lyme patient. And again, we can speak for this for many hours for this. These are citations from abstracts and from published peer-reviewed literature of patients who are treated with late-stage Lyme disease with what are thought to be appropriate treatments for 2 to 4 weeks and who are proven antigenically to have, either by culture, by PCR, by other antigen capture assays, to have still harboring living spirochetes. So it's not one case report, it's not just an anecdote here and there. Here we have many citations, and since I made this slide, I picked up several more. Okay, so we know that we need to treat longer. What is the end point? To make a very long story short, the patient has to be free of the signs of active infection. Otherwise, if you stop before that point, they relapse. How do you know the patient has active infection? Patient diaries, measurements of as many objective parameters as possible, including records of temperature graphs, records from physical therapists, physical findings such as synovitis, things that show active infection. And one of the things that I've said to my patients for a long time, you've heard again repeated today, if the patients have symptoms that come and go, obviously they're not permanent because they can go away. So treatment recommendations, this is all printed up in the guidelines that I do give out, and they can be gotten from the Lyme Foundation. But a few points I want to make. With oral therapy, I always recommend in chronic Lyme disease that you check blood levels. Amoxicillin, we start at 3 grams a day, but very often have to go much higher, and sometimes it doesn't work at all. With doxycycline, we start not with 200, but with 300 milligrams a day. Interestingly, doxy is a very quirky drug. If you don't get enough blood level, it works not at all. If you get the blood level high enough, it can have some dramatic responses, in fact, in better than parenteral ceftriaxone in some cases. I've had patients successfully tolerate 600 milligrams orally per day of doxycycline, so you have to go and individualize it. Ceftin, cefuroxymaxatil, is another alternative. We start with 1 gram twice a day, check blood levels, sometimes even that is not enough. One thing we'll go, well, next slide I'll do quickly. Augmentin, used commonly, it only contains 500 milligrams of amoxicillin 3 times a day. It's not going to be enough. It's not even worth doing unless you're adding amoxicillin to it as well. Some tricks for parenteral therapy. Ceftriaxone, you're aware of the risks of gallbladder problems because of the GI excretion of ceftriaxone. C. difficile has been a problem. Over the last year, I've treated my patients interruptedly. In other words, I give the ceftriaxone 5 days per week in a row, and I skip the weekends. Since that time, and I hope I'm not jinxing myself, I've not had a single case of gallbladder problems or C. difficile from that Rosefin treatment, even using as high as 4 grams a day. Cefotaxime seems to be safer. It can tolerate up to 12 grams a day. Intravenous doxycycline is a great drug, but very difficult to tolerate. You need a central line, cannot be frozen because otherwise it precipitates and plugs the line, and can be surprisingly effective, but still needs blood level measurement. I talked about benzathine penicillin. Again, the guidelines are more detailed on how to use it, but basically we start with a very small dose because we have seen prolonged and fairly severe Herxheimer-like reactions with what are often small doses. So we often start very small and slowly build up over several weeks to several months. Alternate scheduling of antibiotics can be very helpful. The specific one I'd like to mention very briefly is pulse therapy from Preac-Merzic. Consists of using a parenteral or an oral antibiotic 2 days per week in a row, using double the dose. It allows you to double the doses, for example, cefotaxime 12 grams a day. It allows you to use more toxic medications with less risk, such as vancomycin, might allow easier access for intravenous and more agreeable lifestyle, and can be effective when conventional regimens have failed. Combination therapy is very widely practiced, not studied, and it should be. Apparently, the benefits include alterations of blood levels, differing sites of action, intracellular as well as extracellular, and perhaps synergism, although this has never been proven. Quickly through management, I don't like to give my patients severe Herxheimer-like reactions because they can be detrimental and be very difficult to recover from. Very important to remember, Lyme is a Borrelia, a relapsing fever type Borrelia. 4-week cycles of waxing and waning of symptoms is part of it. Don't confuse a waxing and waning cycle with a failure of a therapy. Acidophilus and yogurt is a routine in all my patients. There is enough literature nowadays to support the use. Vitamin supplementation in small amounts is helpful. We know from Felsenfeld's work back in the 50s, 40s, and 30s that vitamin B is essential for healing of the nervous system. I always check B12 levels in my chronic patients. Very often we find occult B12 deficiencies that can be treated and should be treated. In work with chronic fatigue, which does have many features in common with chronic Lyme, the use of essential fatty acids was proven in a double-blinded placebo-controlled study to have statistically significant improvements in fatigue, aches, weakness, vertigo, dizziness, memory, concentration, and subjectively depression. And this seems to hold true for the chronic Lyme patient. CoQ10, you've learned, is ubiquinone in medical school, documented on serial cardiac muscle biopsies back in 1993. Dramatic improvements in cardiac function and general well-being were observed. And finally, with the rehab program, I've been a big advocate of rehabilitation. I feel the patients with chronic Lyme will not recover fully without an active, aggressive rehab program. Contraindications, basic common sense in terms of some of them, some interesting things in terms of others. It's found that avoidable stresses should be avoided, sleep deprivation should be avoided. Some soft literature is now available to show that these have negative effects on immune responsiveness, and anyone who's treated Lyme patients or those who have Lyme know if you don't sleep well or if you're overly stressed, you're not going to feel as well. Okay, if the treatment was adequate and you're still not doing well, what do you look for? Obviously, number one, you search for alternate diagnoses, such as connective tissue diseases, malignancy, so forth and so on. Don't forget endocrine problems, especially adrenal ones, heavy metal toxicity, carbon monoxide poisoning, insecticides, and so forth. Look for concurrent diagnoses. Many of the Lyme patients have C. difficile colitis, and it may not be that obvious. Those patients with Lyme and C. difficile feel worse. The C. difficile aggravates the syndrome. H. pylori, thrush, or others that can add to the Lyme-type symptoms. If a patient has been adequately treated and still does not do well, still has signs of persistent infection, an extensive evaluation of the immune system is then in order, especially looking for historical use of steroids or other immunosuppressants during the course of infection. We do function studies on B cells, T cells, and killer cells, and if deficiencies are found, they're tried to be corrected if possible. And there is now a mouse model of genetic susceptibility to chronic aggressive Lyme disease, and it is inherited as an autosomal dominant. I don't have the citation in that literature, but it is present. If there's a very large overlay of chronic fatigue syndrome, you don't dismiss that, you try and treat it, including with kudopressin, parenteral magnesium, intravenous and intramuscular gamma globulin, and amantadine. And finally, hopefully the last slide, is adjunctive therapy. Obvious things such as analgesics, muscle relaxants, NSAIDs, and so forth. But immunotherapy, including Sinequan, study that was recently reported on showed that the use of Sinequan, brand name incidentally and not generic, in small doses has definite beneficial effects on T-cell function, even in those patients who do not have T-cell functional deficiencies. And clinically we do see it does help. All right, I'm sorry I buzzed through so quickly, but I want to give an overview. You have to treat and approach logically all the aspects of Lyme disease and get back to the basics. And my favorite slide, let's wipe out Lyme. Thank you.
Okay, I have a full 2.5 minutes, so I'm going to talk real fast. Continuing with our thoughts earlier about a different way of doctoring, I'd just like to make 3 points. First, a distinction has to be made between early localized disease, such as that seen with a single erythema migrans and no constitutional symptoms, this sort of thing, where in this situation with a single erythema migrans and a person who has no flu-like illness, I feel very comfortable treating this for 3 to 4 weeks with oral antibiotics, and I really haven't seen much in the way of complications here. The distinction has to be made between this and this, which is disseminated disease, multiple erythema migrans with constitutional symptoms. In this case, this woman had fever, chills, cystitis, myalgia, memory loss, confusion, and this represents metastatic Lyme disease. To comment earlier on what Dr. Masters and Dr. McManus were discussing in the last session about the percentage of people that have multiple erythema migrans, what I find is that a lot of times patients won't come in and say they have multiple erythema migrans, but the people that have high fevers or that have systemic illness take their clothes off, look at them carefully, make sure that they don't have a secondary lesion somewhere. Those are the people you're going to see it on. I've been using 3 to 4 months of oral antibiotics for this type of patient in this situation, or until the patient is completely symptom-free. We'll talk about which antibiotics to use in a minute. The second point I want to make is about a rational approach to antibiotics for treating persistent Lyme disease. Once you've made the diagnosis of persistent Lyme disease, what are you going to treat with? Now, if you use third-generation cephalosporins, or for that matter, second-generation cephalosporins, remember the complications. Bleeding problems, elevated liver functions, and abuse effect, superinfections, and certainly the costs. These problems are real. And of course, there's always the problem of remembering the names of these dang things. You know, cephalowonderful, cephalocostly, gorillasporin. I've been using a lot of Cef du jour lately. If you do have to, or if you still are using cephalosporins, particularly Ricefin, remember you only really need 2 grams a day to have good tissue penetration rather than higher doses, which really only add to the side effect profile. What I do, however, when deciding which antibiotic to use, I take the Mae West approach, and that is, when I have to choose between 2 evils, I always choose the one that I haven't tried before. For early disease, for disseminated disease, and for persistent disease, late disease, I use tetracyclines. And when I say tetracyclines, I mean doxycycline or minicin. And there's multiple reasons for this choice. First of all, there's minimal side effects. They're very inexpensive. Minimal hassles for the provider. There's multiple things coming out recently, including Dr. Danta's eloquent thesis, which supports the use of tetracycline. There's published reports that minicin is being used effectively as a first and second step therapy for rheumatoid arthritis. And of course, tetracycline has a good track record, and the tetracyclines have a good patient satisfaction profile. And I challenge anyone to show a superior result with a large population of patients using any other oral antibiotic or IV antibiotics compared to the tetracyclines. The third and final point I want to make goes back to the original study that we talked about earlier, done in Northern California. Something else is happening in Northern California, and I feel like Lyme disease is really not the only thing we're seeing. We're seeing Lyme disease as a syndrome. We're seeing ehrlichiosis in our population, and the tetracyclines will cover ehrlichiosis and many other organisms. One more reason to consider doxycycline or minocycline as your major mainstay of therapy. Thank you very much.
Okay, the finals. Finals.
Right, the final speaker of this afternoon's session and of the entire conference in its own right is Dr. Fallon from Columbia University, who's promised to speak on time.
I promised to speak on time, but I'm already beyond time. First slide, please.
You have.
Oh. This one, okay. The question I'm going to address is persistent encephalopathy, to treat or not to treat. I don't actually give the antibiotics or use the antibiotics. I sort of follow patients as they're being treated by various internists. So I'm going to report a little bit on how I evaluate patients and what I'm seeing in the patients who I work with. And I'm giving you this slide just to tell you, if you ever want to ask me a question in the question section later, I can tell you about a really interesting patient who did this on the Wechsler memory scale visual recall question. And the patient is asked to look at the 2 figures on the right for 10 seconds each, and then to copy it down on a piece of paper by memory. And at time 1, that's all the patient could do. And this patient had severe Lyme encephalopathy. At time 2, just 2 months later, the patient was dramatically improved. Now, what I want to say about this patient is at time 1, this patient had already received 4 months of IV antibiotics, had positive Lyme serologies, positive CSF serologies for Borrelia burgdorferi, and because the patient continued to have persistent symptoms, the internists and psychiatrists felt that the diagnosis was really a dissociative disorder, so they wanted to admit him to a psychiatric hospital for treatment. His family said no, took him out of the hospital, and got him appropriately treated, and I'll tell you later if you want to know what the treatment was. So how do I evaluate patients when they come into my office as a psychiatrist with persistent symptoms? First, I ask, is the diagnosis of Lyme encephalopathy correct? Because lots of other things that can cause memory problems. Secondly, are there comorbid psychiatric disorders that could be treated better? And this is extremely important because a lot of these patients do have concurrent psychiatric problems such as depression, panic attacks, behavioral disorders, and there are a variety of good psychiatric medications that can help with those problems. Oftentimes it's very hard to distinguish major depression from Lyme encephalopathy. So if you have a patient who comes into your office who has disturbances of sleep, concentration, energy, that could be just purely the encephalopathy, or it could also be, or otherwise be, major depression. So you want to ask, is the person also hopeless? Does the person have suicidal thoughts? In fact, some patients do end up killing themselves, so it's very important to take the psychiatric aspect seriously. Developed a psychogenic seizure disorder, and the third developed a psychogenic movement disorder. Now, what kind of clues can you use to determine whether something is psychogenic or not? Well, certainly if let's say with a movement disorder, if a person has an abundance of different types of movements and it all occurring in the same person, that's more likely to be psychogenic. If the person is able to reproduce the symptoms for you on demand right in your office, that tends to be more likely to be psychogenic. If just before the session ends the person has a seizure in your office, well, that sort of increases the odds. The interesting thing is that these are not consciously put on phenomenon, but these are unconscious events that the body produces. So some of these patients will actually take videotapes of themselves having these abnormal movements. And finally, you want to ask, what was the patient's response to prior antibiotics? Did they get better or didn't they? How long was the course, what route, and was there a subsequent relapse? I want to list and just talk very briefly about attention deficit disorder, because a lot of the patients with Lyme encephalopathy who come into my office have a lot of these symptoms. They make careless mistakes, they have a hard time sustaining attention on tasks, they often don't seem to listen very well when they're spoken to because they're in a fog, they often fail to finish tasks that they start. They often have trouble organizing themselves. It's almost impossible to get a clear history sometimes from these patients. They often lose things, and they're easily distracted. They go into a room to do one thing, and they end up doing the other because they get distracted. Now, it's important because you can help these patients symptomatically by treating them with psychostimulants or with something like Wellbutrin, which is an antidepressant that, at least in open trials, seems to be effective in helping attentional problems. And this can be highly debilitating, the attentional problem, so it's worth treating it symptomatically. We wanted to do just a very preliminary pilot study to look at what happens to patients who have already received a good bit of oral antibiotic treatments and a good bit of IV antibiotic treatments. What happens to them? First of all, how disabled are they? Secondly, are the repeated courses of IV antibiotics that these patients get effective? Are courses of IV antibiotics more effective than orals? It could be that they're just the same. Or maybe patients on no antibiotics would do just as well. Finally, does the degree of diagnostic certainty of Lyme disease based on serologies relate to the likelihood of responding to treatment? You might expect that people with much more convincing serologies would do better. So we performed this open pilot study, and what we did was we got a bunch of patients who were diagnosed as having Lyme disease by their internist. I confirmed the diagnosis based on their symptoms. They had to have a history of exposure to a Lyme endemic area, history of at least one positive diagnostic test or of erythema migrans, symptoms of Lyme disease for at least 3 months. Most of them had had it for over 2 years. No more than 4 months of prior IV antibiotics. They had to have received IV antibiotics, but they couldn't have received more than 4 months for entry into the study. And they had to have complaints of memory problems. All patients received standardized structured interviews to assess memory, attention, executive function, anxiety, depression, and disability. The neuropsych testing was done at baseline and then again 4 months later. And the neuropsych testing was done by an interviewer who was blind to the treatment they received during the interim. I was not giving them a treatment. I had no impact upon what treatment they got. So basically, these were patients who were being treated by their internist, and I was following them naturalistically. The patients had typical Lyme symptoms of memory loss, arthralgias, mood changes, headaches, fatigue, shooting pains, word-finding problems, weakness, photophobia, neck pain. About a third of them had a history of erythema migrans and fasciculations, and only 11% had a history of Bell's palsy. Mean age was 41, most were female. Mean length of prior oral treatment was quite long, almost a year. Mean length of prior IV treatment was about 10 weeks. They were not significantly depressed, and they had sort of mild to moderate levels of anxiety. Diagnostic test results. In terms of, I just want to focus on the serologic summary. 13 out of the 18 had a history of a positive blood test for Lyme disease. 4 out of 18 had equivocal tests. 1 out of the 18 was seronegative. The seronegative patient had a positive urine PCR and a history of erythema migrans. Only 6 of the patients had had spinal taps, which is interesting because these were patients who complained of cognitive problems. Okay, now what treatments did they receive during the interim? As it worked out, actually worked out by chance kind of nicely, there were only 18 patients. It's a small sample size. 5 patients got IV antibiotics, 5 patients got intramuscular antibiotics plus oral, 5 patients got only oral antibiotics, and 3 patients got no antibiotics. They got a range of different antibiotics, as you can see. In the IV group, some patients got Primaxin, some got Clafrin, some got Vanco, one guy got Rocephin. So it's a naturalistic follow-up. In terms of disability, how disabled are these Lyme patients? Well, compared to patients with other medical illnesses such as congestive heart failure, diabetes, major depression, on the RAND disability questionnaire, patients with Lyme disease did markedly worse on all measures of energy and fatigue, social functioning, pain, etc. Now, if you take patients and just compare those who got IV antibiotics to those who didn't, what you find is that the patients who got IV antibiotics were more disabled, as you might imagine, than the patients who didn't, which would be the blue and green lines. After the IV antibiotics during the interim, time 2, when they came back, they reported feeling a lot better. And there wasn't much change in those who did not get IV antibiotics. Now, you could say that's just a regression to the mean for those who are most disabled. Now, if you look at the percentage improvement between time 1 and time 2 among the persistently symptomatic Lyme patients, what you find is that there was a statistically significant improvement in the IV group on the dimensions of decreased pain, improved social functioning, improved role functioning based on emotional issues, and there was a trend towards significance for decreased fatigue and improved energy. Now, in looking at the neuropsychological tests, on the baseline scores, what you see is that there's not much difference between the oral group, IM antibiotic group, and IV antibiotic group, but it looks like those patients who didn't get antibiotics did score lower. So you might expect that they would improve more because they might move up to the mean, have more to move in terms of going up to the mean for the group. And similarly, in verbal memory, the patients who had not gotten antibiotics during the interim were lower, but the others were pretty close. What you see is in the orange bar, under visual memory, the IV antibiotic group was higher than the others, so you might expect that to drop down. And this is basically what we found in this very small sample with lots of problems in the study design, but just to talk through what this shows is that the patients who got no antibiotics tended to do a little worse in verbal memory and visual memory. Patients who got IM antibiotics, the yellow bar, seemed to do much better. And that was shown also in general memory and in delayed recall. Patients who got IV antibiotics during the interim really didn't have a very dramatic improvement. If you group together the IV and the IM antibiotic group and compare it to the patients who got oral or no antibiotics, there was a trend towards significant improvement in visual memory, general memory, and verbal IQ. Sample size is small, there are lots of problems, and I'll be done in two seconds. I looked at a few confounding variables. Were psychiatric meds given anew in any of the groups? The answer is no. Were the patients given IM antibiotics more cognitively impaired to begin with? The answer is no. Was the interim antibiotic course briefer for the other treatments than it was for the IM group? And the answer, in comparison to the oral antibiotics, is no. But the IV antibiotic group, they only had treatment during the interim for about 9 weeks. It could be if they were treated for 18 weeks of the interval that they would have done as well. Was the diagnostic certainty of Lyme disease greater in the IM group than in the other groups? The answer is no. Of the 5 patients in the IM group, 2 had equivocal serologies to begin with. Both of those patients ended up doing well. In fact, of the 4 patients with equivocal serologies in this pilot study, 3 out of the 4 ended up showing clinically meaningful cognitive improvement. There are lots of limitations to the study. Treatments were not randomly assigned. Treatment itself was not controlled for. Antibiotic duration prior to the study varied. This study, I really relied heavily on clinical criteria as well as serologic, and that you could say is a problem. And really, I should only have been looking at the serologic criteria, but I think it provides some interesting and provocative results. So these are very tentative conclusions based on a flawed study. But among patients previously treated with 4 to 16 weeks of IV antibiotics who had persistent symptoms of cognitive impairment, IM bicillin may be particularly beneficial. A repeated course of IV antibiotics may in fact reduce pain, as well as improve energy, emotional health, and social functioning. Because selected moderate certainty cases, in terms of serologic certainty, responded well to repeated antibiotic treatment, treatment decisions, again, should be based on clinical criteria rather than on serologic tests alone. And finally, we need well-controlled treatment research with a much larger sample size so that the errors in this study can be wiped out. Thank you very much.
Well, I'm sorry that I was just told that due to management problems, we have to go to the public forum. So.
No person is an island unto themselves. It is through the commitment and support of others that we are able to sustain our efforts and focus our energies. Our organization has been most fortunate to have worked with these individuals for many years. In the process, come to appreciate how much they have done and are doing to educate others about this disease in Canada. They have been the Canadian pioneers who have battled the disease and the denial and ignorance which surrounds it. They have done this often alone, at great personal sacrifices, and without recognition. It is with the greatest pleasure now that we finally are able to recognize them. And on behalf of the Vancouver Lyme Borreliosis Society, I would like these special people to proceed to the front. If you would kindly hold your applause until all the words have been given, thank you.
The bacterium is usually considered to look like, although it takes a wide variety of shapes. It was well explained today. Transmission is by a tick that is infected, transmitting it to humans. But the way it usually works is ticks have 4 actual life stages. You see listed here that we have listed 3 active life stages, but there's actually a 4th to its life stage, which is the egg. When it hatches, it's an egg, and it hatches and moves over to a larva. The larva then may feed on an infected animal, and you need to know that this infection is maintained in nature by the mammals that are out there. I think of it as the critters in the woods usually. And it's ticks that take it from one critter to another to help keep that infection out there. If the larva feeds on an infected host, it picks up the infection and will stay infected throughout the rest of its life. That means that it can emerge as a nymph once it molts and is infected as a nymph and as an adult. Proved vectors are black-legged ticks and western black-legged ticks. Those are 2 types of ticks that are very visually indistinguishable. They look similar. And under investigation is a tick in the Midwest that's considered the amblyoma, the Lone Star tick, and that can be found as far east as New Jersey. And this is what the tick will look like as it goes from larva to nymph to adult male to adult female. This also shows what a regular dog tick would look like and what the Lone Star ticks would look like. And instead of going into detail on each of these, which I'll tell you the truth, is very imposing to be up here with all the scientists that you read about all over in all the publications and trying to give a little lay explanation of this. And this is what they look like when you size them to a pencil. This is the engorged dog tick, the female dog tick. Here is an unengorged female tick and an unengorged, the males don't engorge, but it's these are dog ticks. Over here is the size of the larva. These are nymphs. These are adults. And if I can see it correctly, these are the adult males, and these are adult females. And when the female feeds, this is a Lyme tick over here. The adult female feeds, this is the size of an engorged fed tick, and it's about the size of a raisin. This is about the size of a dot on top of an eye. And rarely are larvae ever infected. It's very rare for it to go from the adult female, infected adult female, to the eggs. Therefore, you find very few of these infected. Early symptoms of Lyme disease can be confusing to many people, to lay people, and what we hear from most people around the country is it just feels as if slowly you grow old. Early symptoms, once you're bitten by an infected tick, and it may take a matter of days to pass on the infection to the person that's bitten, as it takes its blood meal. You may come up with flu-like illness with aches and pains and fever, and you may get what is considered a characteristic rash. And that rash may be with about a third of the people, in some studies all the way up to 80% of the people. And usually these studies are talking about light-skinned people and not necessarily people of dark color. Usually the rash occurs at the site of the bite, and it's around where the tick was. You wouldn't consider a rash someplace else as an early disease. It can look reddish purple on light skin, and on people of darker color it can look like a bruise. There's usually what they consider central clearing, so it almost radiates from where the tick bite is and it gets larger, almost as if you threw a stone into a pond and you have the ripples that go outwards. Sometimes at the foundation we get calls from people with bites, and at the time of the bite they have skin discoloration, and what we try to let people know, besides calling their physician, is something that occurs really. And you can see the rings of discoloration where it gets larger, and it's reddish color with some clearing, and then darker reddish color. Sometimes the rash isn't what you would expect from reading the papers or reading some of the books as to how the coloration has to be central clearing. Sometimes it's uniform colored, like here. And this is a triangular shape. This is actually from Dr. Scrimenti, who's someplace up here, and showing that this is about the thumbprint size of a rash from the bacterium that was transmitted to the patient from the bite of the tick. So it can be very small, and that may contribute to why sometimes very few people notice the rash. This is a long oval shape to the discoloration. And those are the things that people need to watch when they get a bite, is they need to let their physician know in case a physician wants to do something right away. And they need to photograph it if they get any kind of discoloration or any kind of rash, because you may not get into the physician within time to have the physician see it. We also suggest to people sometimes to mark it with a pen, because by the next day you get in, and over the next several days, if you don't get in that fast, you can actually photograph it with this little ink mark that you have on your skin as it enlarges. If you receive some people get multiple rashes per bite, and that may be a sign of disseminated disease, where you get the bite like over here, and you wind up with no other bite, but you have rashes that come out across other parts of your body. There's also other kinds of conditions that can occur with the skin, that if anybody has any questions, you can ask as we go along, that include benign skin tumors and a leathery kind of condition that occurs on the hands and feet. Neurologic problems can occur with a number of patients, which include headaches, meningitis, and what they call cranial nerve palsies, where you might have some facial paralysis or some hearing problems or some problems with taste or smell. And you might notice some strange sensations at different parts of your body from the nerves. Things don't feel quite right. Or you might notice cognitive or behavioral changes. And what we hear a lot of times with patients that have Lyme disease, it's the spouse that complains a lot, that the spouse wants their partner back to where they were before they got Lyme, because they're so cranky. With eyes, any part of the eye can be affected. And the thing that we notice is there aren't that many people that have real serious eye problems. It seems to be, from what we get reports, primarily joints and neurologic. And some people get irregular heartbeats, some sort of different degrees of conduction defects, and a number of people get problems with joint aches and pains and swelling. This is an example of multiple rashes per bite on oriental skin. And there is actually, I don't know how easy it is to see back there, but there is actually a rash here, there's a rash here, and I believe the bite's here, and there are rashes over here and over here on this leg. This is an example of facial paralysis, and this woman is able to close her eyes and smile, but this side is unable to respond. This is the normal, this is the abnormal side, and this is the more normal side. The diagnosis of Lyme disease is a clinical one based on symptoms. It can't be based on just going and getting a serology or getting a blood test. And that's important to remember for patients as well as physicians. That's also endorsed in the states by the Center for Disease Control as well as the National Institutes of Health. And that laboratory testing is just another piece of information in a complex history. There are a number of problems with some of the laboratory tests, and it looks as if a lot of the tests that are on the horizons have significantly overcome some of the drawbacks that they've had in the past several years. On the treatment of Lyme disease, from what we've seen, since there's no test that can prove the absolute presence of the bacterium that causes Lyme disease, and then can show that all of the bacterium is eradicated, there's no absolute way to tell which is the best antibiotic. So various antibiotics are used in the treatment of Lyme disease, and there are huge controversies, beyond proportion, as to which one's the best, which route's the best to go by, whether it's oral or IV or intramuscular, whether it's one category of antibiotic or another. What we encourage people to do is have a very good doctor-patient relationship with mutual trust and respect, and you need to talk about your symptoms and have a long-term rapport with the same physician that you've been going to throughout your disease. What it appears to be is what people had said for a long time, that early diagnosis and treatment at that time helps lessen later complications. The types of things people need to know is that most times you can prevent this disease, and that it's up to the individual person to take precautions themselves to prevent getting this, because once you have the disease, a lot of times you wind up in a black hole of no absolute answers. So it's easier to prevent it than it is to get into the controversies and the status of being a patient. The way you prevent it is you avoid tick-infested areas, you wear light-colored clothing and long sleeves whenever you can, unless it's obviously a very warm summer day. You tuck your shirts into your pants and your pants into your socks. And that's to remember that ticks crawl upwards. And if you keep the upper layer of clothing tucked into the lower layer, the ticks will stay on the outside of the clothing, so that when you wear light-colored clothing, you can see them more easily. Use EPA, use approved tick repellents. In the States, we say use EPA tick repellents. Most often, if not always, those are DEET-containing repellents. And we're just getting reports back in, at least from one company that's just tested its 25% DEET product, that it's inadequate to repel ticks. Their concern is that there was a product, a chemical in there called R11 that used to, as of I guess it was 1990, maybe 1991, that they voluntarily pulled out because of concerns that it was a carcinogen. And so there hasn't been any full testing of DEET products since then, except for this first report we have that shows concerns that the 25% may not be adequate. That puts people into the wonderland as to whether DEET is totally safe, whether people get adverse effects. And we tell people, put the products on your clothing. And you need to do daily tick checks after being in tick-infested areas. That includes getting naked and checking yourself and your skin for ticks, because there is a window of opportunity, even if the tick is feeding on you, that if you get the tick off, you won't get the disease. And inspect clothes hourly when you're outside. This tells you about tick checks, proper tick removal. We've actually had a nice presentation today on an alternative way to remove a tick that involves injecting some solution underneath your skin and getting the skin to bubble up. But for now, we recommend that you take fine point tweezers, put it at the place of tick attachment, and gently pull the tick out. And then you keep the tick in a vial and call your physician to see if your physician has any method of testing that they want to do. Environmental controls involve reducing the area around your house so that it is tick unfriendly, which would mean primarily reducing humidity around your area, keeping the lawn cut short, letting the grass dry out thoroughly between waterings, pruning back trees to allow more light in, also using tick-killing chemicals like Dursban or Sevin, which is not recommended for people within, I think it is 75 feet of wells. So if you have wells, there are concerns with some of the chemicals that you may put on your lawns. And move or remove attractions that bring the mammals that carry ticks in. I hope I've gone through that fast enough. However, for those people that have questions, please feel free to get up at a microphone over here. There's one over here, and there's one over there. And we'll let you ask your specific questions to the experts that are up here. We'll have wonderful, more specific answers for you.
Thank you, Karen. What I'd like to do is open the forum. The protocol is such that we will have written questions answered first, and then we can go to the questions from the floor. What I'd like to do is divide the questions by category so we can get more of a cohesive picture of the types of questions and answers that people want. I'm going to start with the basics, the epidemiology and the biology of the ticks, then we'll move on to the illness of Lyme itself. I think a reasonable opening question is directed toward John Anderson. Question is, since Lyme was discovered in the mid-70s, was the bacteria there all the time and we didn't know it? Is it a new illness? What's the past history of Lyme disease in this country and in Canada, if you know it?
I'm John Anderson. Is the mic on? Lyme disease, although it was originally described in Europe, and the spirochete first isolated and described here are in the United States by Dr. Willie Bergdorfer and his colleague Ellen Barber. That spirochete was present in North America, probably long before Europeans came to this country. Clearly, studies with PCR, this is a relatively new molecular biology technique, has shown that this spirochete was present in ticks collected during the early part of this century, as well as in white-footed mice in eastern North America. More than likely, this spirochete was present here in North America for hundreds of years.
Thank you. And for Dr. Banerjee, in Canada, what types of ticks contain Lyme bacteria?
In Ontario and Atlantic provinces, the Ixodes scapularis. In British Columbia, we have isolated from Ixodes pacificus, Ixodes angustus. Recently, we have isolated from Haemophilus leporis palustris found on snowshoe hare rabbit. Yeah. In Alberta, Grand Rapids. We have also seen spirochetes, but spirochetes, dead spirochetes, in Ixodes banksii, Ixodes marksii, which came from Ontario. Whether those specific ticks are not competent enough to continue the process of keeping the bacteria alive, we do not know at this moment. But this has been said. Two reasons. First is money. In order to go for the field work, you need a lot of money. We are fortunate we had a lot of volunteers. So when we started the work in 1986, we were depending on the ticks which were submitted to us, either by the volunteers or BC Borrelia Society volunteers, veterinarians, Ontario volunteers, etc. Almost always we have got nothing but adult ticks. Only when we had few patients who are really positive, and Dr. Bergdorfer's laboratory proved them, then only we received the blessings and had little money to go to the areas where these patients were. We trapped the rodents, retrieved the ticks from them, cultured the ticks, also flagged the ticks in those areas. Lo and behold, 92 for the first time, we started having positive tick cultures, rodent cultures. And we found that in the ticks, we had hardly 1% infectivity. In the rodent where we collect the rodents and culture 6 organs, we had 4.5%. This has, I have shown in my paper, that this has gone up every year, and it has been 1995, we had 3% in the rodents, still about 1.8% in the ticks. So the reason we did not get before was we were going up the wrong tree. We had to go to where these things are surviving, to the host and to the vector, that means to the rodents and the ticks in the wooded area.
And you're not off the hook yet, we have more questions for you. In Canada, is Lyme disease reportable, and if so, to whom and by whom?
Would you repeat the question, Karen?
Sure. In Canada, is Lyme disease a reportable illness, and if so, to whom does it get reported and by whom? And if someone wants to know the statistics, where do they go to find the numbers?
Well, the reportable disease in BC recently, I think I would rather like to address the first part of the question. Second part, I would rather like Dr. Daly to answer. Second part of the question, the statistics. To date, we have about 201 cases in Ontario. Out of those cases, only 12 of them is really in the focal point, which is Long Point, Ontario, where you have lots of birds coming into the sanctuary from New York State. So you perhaps gave us the bacteria there. But rest of them are all from all over Ontario, a vast area. In BC, we have 43 positive cases. When we looked at the questionnaire answer, the epidemiological data, we find only 11 of them we could really pinpoint, but these are infected in BC. But the question is, this is tip of the iceberg, because we are all dependent on the people who came to their physician. The physician believed their stories and sent the specimen to us. There are maybe hundreds of them who have never presented themselves to their physicians. Now, the reportable thing, BC has just got in. Last year, it was declared as a reportable disease. So Dr. Pat Daly, who is an epidemiologist, the government of BC, would be able to answer it better than me. Dr. Pat Daly, kindly.
Thank you, Dr. Banerjee. As he mentioned, Lyme disease was made reportable in British Columbia in September of last year. It's also reportable in some of the other provinces, like Ontario, although not all the provinces. And what that means is that physicians who make a diagnosis of Lyme disease, or laboratories who diagnose it, are required to report those cases to their local medical health officer at the public health unit. The medical health officer then determines if those cases meet the case definition that we use for surveillance. And this definition was arrived at a consensus conference in 1991. The definition that we use for surveillance is not meant to guide the diagnosis and treatment of patients by physicians, because it's quite a stringent definition, but it's what we use for surveillance because we want to be sure that the cases we're counting truly are cases of Lyme disease. So the medical health officer will then report the case to the provincial epidemiologist, which is the department where I work, and we in turn report cases to the Laboratory Centre for Disease Control in Ottawa, the federal government. And although it's not reportable in all provinces, the federal government does canvass all the provinces to look for cases. And I believe it's now, cases have been found in 8 of the 10 provinces as of this year. There's been, as Dr. Banerjee said, there's been about 200 odd cases reported, most of them being from Ontario.
A question open to the panelists regarding the similar type of topic in America. Is it a reportable disease? What states in America has Lyme been found in? And who's doing the reporting, the surveillance, and so forth? Anybody want to take that one?
Can you hear me? Okay. I'll take the privilege of answering that question. My name is James Harrington. I work for the Centers for Disease Control and Prevention in the U.S. And Lyme disease is reportable in the U.S. It became a reportable disease in 1982. And there were 11 states that reported 497 cases during that year. Since then, in 1994, there were over 13,000 cases reported by 43 states. It's a reportable disease and is tabulated by the Centers for Disease Control and is published weekly in the morbidity and mortality weekly reports, which are available to the public on demand.
Does anyone feel that Lyme disease is being underreported? And if so, why? I'm not asking you guys, this is for the panelists. How about if we ask some of the clinicians? How about Jim Castle? What do you think? Do you feel Lyme is being underreported?
Do I think Lyme disease is being underreported? No question about it. I can only speak from my own experience to tell you something I probably shouldn't tell in public, but I don't report Lyme disease anymore. I did up until 2 years ago when I walked into my local public health office in Northern California and handed them about 150 cases for that year on a form that they wanted. And someone earlier today at one of the lectures described what some doctors go through. I was intimidated. I was made to feel like some of these cases really weren't Lyme disease. And I felt really bad about it. And it took me a long time to fill out those forms. And as a protest, I just stopped reporting. So I know that cases go unreported.
Martina, Ziska?
Yeah, we did a survey. We surveyed physicians, about 100 physicians in the U.S., and one of the questions we asked them is, are you reporting all your cases? And the answer was in 95% cases, no. We asked them also for reasons why. In 60%, it was because too much paperwork. In 50%, they said it's a nuisance. And in about 20% cases, they said it's because they are unsure of the diagnosis.
I believe that earlier today, the gentleman from the CDC mentioned that he thought it was underreported by a factor of 6 or 7. Diseases are generally underreported. A factor of 10 is often used but that's just a guess. The figure of 6 or 7 suggested by the CDC presumably is somewhat better than that general figure of 10 to 1. That is, 1/10 of the cases are reported that is commonly used.
Okay, how about a practical question? Let's say someone has a recognized tick bite and they want to have the tick tested for Lyme disease. Where do they send it? Who sends it for them? And how should the tick be transported to keep it alive? Or must it even be kept alive? Let's ask that both for Canada and the United States.
If you have been bitten by a tick, this is the regulation we follow. You take the tick or go to your physician. The physician will perhaps help in removing the tick, but if you have already removed, put the tick in a small plastic vial with a wad of cotton moistened with water, and the doctor will fill in a form, Borrelia form, and will send it to us by mail. If you are away from your physician, if you are somewhere in the interior area, you can go to the nearest health unit, they will accept from you, and they will send it all back to the British Columbia Center for Disease Control Provincial Lab, to my laboratory, Vector-Borne Diseases Laboratory. So this is perhaps also followed in other states, but I can't say anything about the other provinces of Canada.
I'll comment about the situation in Connecticut, USA. Citizens in Connecticut can send in ticks through their local health departments to us in New Haven at the Connecticut Agricultural Experiment Station. The ticks will be accurately identified, and they will be tested for the Lyme disease organism, either by culture, by a procedure called the indirect fluorescent antibody test, or by the polymerase chain reaction. We prefer to attempt culture, but the fact is that 3/4 or more of the ticks that we receive are dead upon arrival, and therefore this procedure called the polymerase chain reaction must be used.
I have one more question from the podium, then I'd like to see if there are any floor questions regarding the epidemiology or the tick aspect of Lyme disease. One question is, when is the tick season in Canada, in this part of Canada, and how do the ticks survive over the winter?
In BC, we have seen actually 2 peaks. One is, say, right now, started in March, April, and the other one will be about September, October, November. But we had a myth in the Ontario area that perhaps in the very cold areas it doesn't survive, but recently we found the northern area of Ontario, which is very cold, they have a very good snow cover, and the tick survives under the snow cover. So if you get a tick, even in month of January, somehow on you, that tick, if it bites, might be positive. So we generally get 2. One is in the between, say, April to June, and then another one between October, November. So 2 pies.
Do we have any questions from the floor?
Okay, my concern basically is concerned with sexual transmission. I'm a former reproductive physiologist, and I'm a full-time Lyme. So my question is this: have any studies been done on ejaculate specimens or vaginal secretions to indicate the presence or absence of spirochetes?
Well, I, for one, do not know of any studies that have looked at those particular specimens.
Okay, if these studies haven't been done, I want to know why.
When I was in Southampton, from time to time we would receive specimens for semen analysis study from patients who had orchitis and who had a compatible clinical illness. And some of those were processed with direct dark field examination. Others were subjected to culture. And we had probably less than 5 specimens. I didn't have a positive isolate or identification, direct identification of Borrelia burgdorferi. But remember that orchitis is one of the established manifestations of the infection, and I think that it is an important question to ask, just as important as the analysis of breast milk to see if the breast milk might transmit the spirochetes. And I think Dr. Burrascano was one of the pioneers in asking that question, and we attempted to answer that way back in the mid-'80s with some studies of breast milk. And we had some positive results at that time. So I think that when you look at data where you have a small number of data points, negative results don't count until you have exceeded a certain statistical base. And so based on 5 anecdotal studies that say no, I don't think that you can say no in the general situation of a person who presents with that.
Right, then why are these studies being avoided? Is it the fact that you don't want to say it's sexually transmitted?
No, I think that the problem in examining tissue specimens is that there is an apathy or there is a more adverse negative feeling in the community in practicing pathologists just not having an interest in looking for the spirochete. The other thing is that the equipment is somewhat expensive, and dark field examination, which I think is cost effective. Dark field microscopy is not available in many hospitals in the United States, so if you have the opportunity to look for another spirochete, Treponema pallidum in a chancre, and you want to get a dark field examination, most hospitals will say, I'm sorry, but we don't have a dark field microscope anymore. Those that do have a microscope might have it put in mothballs somewhere in the back. It's not a frontline technology, and it should be kept in mind that it is a cost-effective procedure for identification of spirochetes and chancres, and that is a skill that you acquire by practice.
Right. So how are you going to answer the question, is it sexually transmitted or not? I know the dogma. So how are you going to answer that question?
I think you'd have to have a combined interinstitutional study, and then you probably have to ship the specimens to a central laboratory where there's expertise from a team of people who see a high volume of material. And I don't think that an individual case studied here and there with a community hospital could be the basis for generating a yes or no to that answer. I think you probably need a combined study.
I think it should be done, don't you?
I'd like to add that there's virtually no evidence epidemiologically for sexual transmission of the disease among married couples, and so there's very little reason to pursue it in an active investigation.
Yeah, but I still want to see the specimens done. I don't see any evidence of that. And no one can answer that.
To follow up on it, in my practice, I looked at scores of patients that had a very high confidence in my diagnosis, and looked at their mates and saw no increase in suspicion for the disease, none at all. But again, small sample, but I know of a lot of other doctors have looked at that too. And at least those of us who are trying to deal with the disease, I haven't talked to anybody that really has a feeling or an impression that it is sexually transmitted. If it is, it would be at an extremely low rate, I would think, or more of us would have picked up on it.
Okay, thank you.
Yes.
I'd like to ask a question on one of the, on the video that was done yesterday on the spirochete actually entering the T-cell. I read a few years ago, I think it was a paper done by Dr. Alan Steer of patients with Lyme disease had less T-cells. And then I noticed your paper said, Dr. Borscano said that there was deficiencies in B and T cells. Could it be possible that we have low B and T cells because the spirochete is destroying them?
I can address that by saying that based on our research, we have no evidence whatsoever that the perhaps invasion and killing of B and T cells that we've observed in the laboratory is clinically significant in Lyme disease. And I would add that although we have seen it, and clearly it appears as if that's the case, the numbers of spirochetes in an infection are probably insignificant in terms of there may be one spirochete per million to 10 million to maybe even 100 million B or T cells in circulation based on the best estimates of the ability to culture the spirochete from a milliliter of blood, for example. And so it would be a very large leap in faith to suggest at this point that there's any particular generalized destruction of the immune system based on the ability of the spirochete to invade and lyse the B or T cell.
Well, I really think that as scientists, I hope that you would keep your minds open to this and at least look into it, especially considering the information that's been given in the past.
Well, absolutely, and the preliminary plans to conduct those experiments have certainly been discussed and are underway.
Thank you.
Questions from the center?
Do fleas or do ticks jump like fleas, fall out of the trees? Hello? Do ticks jump out of trees? Do they jump like fleas? How do they attack? Second question is, why does antibiotics make matters worse?
First question, they don't jump like fleas. They run. They got 8 legs, as you have seen, and they can be very fast to run away from you. The popular idea often is read that I went to this and this area and the ticks were just coming out of trees, falling right on me. Comes from the fact that at certain times during the tick season, the ticks are at a higher elevation than just on grass. They are on just about the size of a deer, belly of a deer, or the back of a deer, that high off the ground, and wait on the vegetation until a deer or another animal comes by. So it's just a popular saying that ticks it has rained ticks out of the trees. That's not true. What's the second question you had about antibiotics? Why do you take antibiotics, you get worse? Who wants to take this one?
Why don't we have Dr. Luft? How about Dr. Luft? Could you speak to us about what we call the Herxheimer-like reaction?
Well, I don't think that if the organism is sensitive and it's the appropriate antibiotic, that it should make you any worse. I think the only time that may happen is that it doesn't make you better, because one, that the organism may be in a part of the body which is which we call a privileged site, where antibiotics do not penetrate. It may not be, you may not be using effective dosing of antibiotics, so that you are not able to ascertain the levels that you need in order to be able to kill the organism. The organism may be in intracellular, as was suggested, although there really needs to be further evidence that it's intracellular in the in vivo, from various pathologic reports. So there's a whole host of reasons why antibiotics might not be active. The organism replicates very slowly. Perhaps at times it maybe replicates extremely slowly, and the antibiotics that we currently use are really most active against rapidly or fairly rapidly replicating organisms. We may need to develop new antibiotics that are targeted at organisms that are slowly replicating, and I think that this is really an important area of research that hasn't been investigated. Most antibiotics that we have were developed for other types of infections, what we call gram-positive infections and gram-negative infections. I don't think there are any antibiotics that were ever developed for spirochetal infections or the particular properties of spirochetes, which may be really very important for us to look at new drug targets. So I don't think antibiotics per se make patients worse. I think the disease may progress, and antibiotics might not be effective for the reasons that I mentioned.
If I can just expand on it a little bit, I think what has happened in the treatment of Lyme disease, especially persistent Lyme disease, patients have noticed a worsening when they take the antibiotics, and that worsening may take a day or two before it begins, and the term Herxheimer or Herxheimer-like has been applied to this, reflecting the old initial syphilis literature, and then after that some plague literature, where during the course of treatment, usually a single shot in the case of penicillin and syphilis, and similarly with plague, that patients seem to get worse, even to the point where they might lose blood pressure, heightened pulse, and the mechanisms of that haven't been totally worked out, but this seems to be a more delayed, if you will, Herxheimer-type reaction, and it's commonly used by patients and physicians who treat Lyme disease. The mechanisms of this with a slow-growing organism are a little bit more difficult perhaps to understand, but nonetheless the principles might apply, but we don't have the proof for it. But that's what's meant by antibiotics making you worse, some of your symptoms, and I think these are fairly common symptomatology, that they do get worse before they get better, and I'm frequently stuck trying to analyze and tell patients the worsening because you're getting better, or the antibiotic is working prior to your getting better, or is it because the antibiotic isn't working? And I know those are hypothetical things, but for now we don't have the proof, but that's the basis for the statement of antibiotics getting worse, making it worse.
We have many, many types of questions, different topics, specifically diagnostic and treatment type questions. So let me ask for just two more questions from the floor before we move on to diagnostic questions. Go ahead.
Thank you. I just wanted to mention a word of support for the Lyme Disease Foundation and other groups around the U.S. and in Canada to make known their educational materials for prevention. The research information is very important to know about diagnostic capabilities and treatment protocols, but I think the real key, as Karen mentioned earlier, is prevention, and that needs to be, I think, stressed, and that let the public know that they can obtain materials that have been developed by the various groups to learn how to protect oneself from tick bites. The CDC has provided funding for educational materials, and our funding's been flat. It's been about $3 million during the last 3 years funding cycles. I think it's very important to understand that in times of limited resources, shrinking resources, that without more funding to provide the kind of research studies that was requested earlier and to provide research into educational interventions, it's going to continue to be that way. Finally, on the surveillance system in the U.S., it is a passive surveillance system. It's not active. I mentioned in my poster presentation that there was probably an underestimate of about 6 to 7-fold the number of cases, actual cases of Lyme disease in the U.S. That's based on a study, an active surveillance study that was done in Connecticut, hyperendemic area, where they actually surveyed populations and obtained information about cases that existed there, and then compared that with what was reported for that area. And there was a difference of about 6 to 7-fold. So in fact, we recognize there is a very drastic underreporting of Lyme disease. However, with a national surveillance system, we can only count. And as long as physicians do fill out their reporting forms and take those few minutes that it takes to do it, then perhaps we'll have a better idea over time what is actually occurring. And I hope Dr. Katzel's experience is not the norm that they would consider that type of a offer on his part to be as such. I think it's important that physicians are respected for their efforts. I think it's very, very busy practices, and to have them help us in our surveillance system, I think it's very important. Thank you.
Karen, do you have a question or comment?
Yeah, I just want to make a comment on Jim Harrington's comment from the CDC. We actually have been provided some funding from the CDC for a wide variety of educational materials, and the information regarding that's available at the front area. Is this on?
Yes.
Okay. But the thing I'd like to do is I'd like to throw a challenge back out to Jim and say that at least in the States, we're basically bankrupting Congress. That there isn't that much money for funding. And I'll tell you, it all comes down to, is Lyme disease a problem? And in the States, if you don't have numbers that accurately reflect the number of people that are undergoing diagnosis and undergoing treatment, then you don't have funding for the kinds of science that needs to be done. So that while the numbers, 13,000 this past year, are fairly small, it's still a rare disorder in the United States. Narrow surveillance reporting criteria to say, oh yeah, well give us lots more money because there's a whole lot of Lyme disease out there. If the CDC had an accurate reflection of the true problem with Lyme disease, with the true number of patients that have it, then it would be something that people could fight for. You could get funds to do all of the studies that need to be done. So by the CDC maintaining a narrow surveillance definition, they are maintaining their budget as a dwindling budget in the years to come. And I think a lot of people would be very pleased to have a broadening of the surveillance definition so that there may be one additional category, maybe voluntary reporting, so you can get a more accurate reflection of the problems that people are having. So if Jim wanted to comment on it or go back and think about it, please feel free to do that.
Last question from the floor before we move on.
I was wondering if Dr. Patricia Coyle's here today? Hi. I understand you're a professor of neurology. Okay, that's why I wanted to direct this to you. I was wondering if first of all, Lyme disease can mimic any multiple sclerosis symptoms. I'm aware that they are, but more neurologically, like maybe an advanced stage or something of that sort. And if so, has there been anything reported of that nature?
Well, some of the neurologic manifestations of Lyme disease can mimic MS. For example, it causes a cranial neuropathy, and one of the second most common cranial nerve involved is the optic nerve. And clearly, optic nerve involvement is a rather frequent feature in multiple sclerosis. About 15% will present with an optic neuritis, and ultimately perhaps 30 to 33% will have an optic neuritis. In the later stages, of Lyme disease, as a late neurologic manifestation, one can see brain and spinal cord involvement that may mimic MS, as well as other sort of brain and spinal cord primary disease processes. So yes, it can, but as I had said earlier in my talk today, I think if you're dealing, if you know and are very familiar with multiple sclerosis, and if you are very familiar with neurologic Lyme disease, then looking at the clinical history, looking at the clinical evaluation, picking the proper laboratory tools to really investigate the patient, I think in the majority of cases you can feel fairly comfortable about saying somebody has MS and doesn't have Lyme disease, or somebody has Lyme disease and does not have MS. And then you have a third group where you have an individual that has MS but also has Lyme disease, because infections in general across the board act as triggers for multiple sclerosis. So yes, Lyme disease can mimic MS, but I think with a very, very careful evaluation and investigation in the majority of cases, you can feel fairly comfortable about what you think is going on with the individual.
Thanks. Just further, though, does it or could it cause demyelination in particular?
There really is absolutely no data that Lyme disease causes demyelinization, which is obviously a hallmark pathologically of multiple sclerosis.
If for pathology reasons, if a sample was taken of, let's say, an area that was denoted as having demyelination, is it possible that spirochete or whatever bacteria it is would be evident or found in the demyelination? Or
well, as I said, from the pathology done from the CSF evaluations, there has not really been evidence of a primary demyelinating condition in Lyme disease. That sort of got mislabeled because some of the initial reports of neuroimaging abnormalities reported lesions in quote, white matter, but lesions there are not necessarily a demyelinating condition. For example, myelin basic protein is not something that one finds increased in spinal fluid of neurologic Lyme patients, and the pathological studies have not found any myelin damage in the central nervous system.
Why then would you use that fluid in conjunction with blood samples to do your PCR test, I believe it's called? Or like what is in the your CFS fluids that you need to conduct that sort of test?
CSF is critical if you are concerned about a nervous system infection. Okay, that's almost true across the board for suspected meningitis, suspected encephalitis. The only neurologic infections in which you might be reluctant to look at CSF would be when you have a mass lesion such as an abscess or a big parameningeal focus. Otherwise, to really get a handle on a potential agent to document there's an inflammatory condition, in general, CSF evaluation is a standard laboratory tool for suspected nervous system infection. It certainly can give very valuable data for suspected neurologic Lyme disease.
I'll have to hit Chuck in the hallway or something. Thanks a lot.
We have a question for Dr. Ligner. The question is, how is Lyme disease diagnosed? And when testing is ordered, what are the better tests to use nowadays to help in making the diagnosis?
I'll re-emphasize what's been said by the CDC early on, that the diagnosis is a clinical one. That is, it is absolutely essential for the physician to sit down with the patient, take a very, very careful history that has to be a very wide-ranging history, asking many, many questions that will elicit from the patient information about whether they have had symptoms compatible with Lyme disease, which can be very varied, often are multi-system in nature. Also, we'll carefully question the patient about what their exposure risk for ticks has been in the course of their life, and that should really include, a survey of, if they're, even if they're a person who is fully grown, what exposure they might have had even going back to early childhood, since we know that the Borrelia have the capacity to stay with the patient for many, many years and possibly their entire lifetime. So I routinely ask patients where they vacationed as children, where they went to summer camp, et cetera, obviously asking them if they have had documented tick attachments. So the clinical history is extremely important, and the physical examination is extremely important. Laboratory testing, even though it leaves a great deal to be desired, is also extremely important, and I think it's necessary at the present time to utilize more than a single laboratory. And for example, in my practice, I routinely send to 2 different good laboratories, and also I generally not only obtain ELISAs, but also Western blots right at the very start, because it's not uncommon in my experience to have dead negative ELISAs and yet very suspicious or fully diagnostic Western blots. So the standard antibody testing, has a role. I feel that you cannot rely upon those tests. If they're negative, it does not exclude the diagnosis of Lyme disease. Now we are beginning to get to be in a position where there are newer kinds of tests, both newer antibody tests that promise to be much more sensitive, and also new direct antigen detection methods where you can try to directly detect evidence of the infection by detecting proteins from the organism or the DNA of the organism using newer methods. Also, I think it's extremely important to look at spinal fluid in patients who have symptoms that suggest central nervous system involvement. Also, I have to tell you, and of course this is part of my presentation that I really didn't have time to discuss, I think it is very important that when one has a high clinical suspicion of Lyme disease, regardless of tests, and that includes all tests that are available to us, if one has a high clinical suspicion of Lyme disease, one has thoroughly looked for other explanations, other treatable causes of the illness, I think the appropriate thing to do, the proper thing to do from a compassionate point of view and also in the best interest of the patient is to offer them a trial of treatment in order to determine whether or not their symptoms are responsive to antibiotics. And very often, of course, you may not be able to draw very firm conclusions, but you can sometimes infer the presence of Lyme disease by response to a course of antibiotic treatment. But sometimes the diagnosis of Lyme disease can be extremely easy, snap of the fingers, and sometimes it can be a very, very, very challenging diagnosis.
On diagnosis also seems to reflect a great deal of frustration on the parts of the patients in that sometimes they have conflicting test results and they don't know where to go next. They don't feel well. Some tests are positive, some are negative, sometimes they're all negative. Can someone comment, please, from the panel, what is the difficulty in getting a test that would be 100% accurate? What is the limitation here?
Well, if the question is why it's difficult to get something that's 100% effective, I think you could say that about most things that we have to deal with in life. Nothing is really 100%. I could spend 30 minutes telling why there are problems with the test, but basically I think there's 2 reasons. One is that you're looking at a bacterium that's not entirely unique. It's not completely separate from all the other bacteria in the world. And during life, we're exposed to different kinds of bacteria. We have bacteria in our intestines and our mouths, and some of these are spirochetes too. So you can have cross reactions. You can have antibodies against the bacteria in our bodies, and some of those will react with the Lyme disease spirochete. So then because of that, because of the cross reactions, you have to dilute the serum out quite a bit. Otherwise, all of us would have these reactions. We'd all be Lyme disease test positive. So when you dilute it out, you gain specificity. the test becomes more accurate, but then also it's at a cost of perhaps loss of some sensitivity. And the other reason the test may not be entirely accurate is that if you have to look at draw the blood at the right period of time. Sometimes early during the infection, the body hasn't responded with antibodies yet, and so it hasn't reached the critical level.
I think I'm going to be a little frank as to why this occurred. During the 1980s, there were these very large budget cuts that came down by Ronald Reagan. And during that time, the CDC was really gutted in regard to standardization of serologic testing. As a result of that, when a new disease came about, and a variety of serologic testing was done by a wide variety of different laboratories, there was extremely poor standardization because the federal agency that was responsible for that had been gutted and that responsibility had been taken away. It's only until recently that the CDC has now gone back to try to standardize this mess. And I think this really kind of points to what happens when an important agency where funding is eliminated from them. Because what happens is that tests are no longer standardized. We're no longer able to have standardization from one laboratory to another. There's no way of oversight to see whether any laboratory is actually performing these tests properly. And I think that this is, we kind of applauded, this type of cuts at one point, but then this is the price that we're paying 5 to 10 years later. And that's really the reason for it. I think that these tests can be standardized, and it's really disgusting that you can go to 2 or 3 different laboratories and get 2 or 3 different sets of results. I mean, it's really, that tells you what the state of affairs are in the serologic industry. And I think we should be taking these companies to task as to why they're gaining great profits at the expense of the patients.
But even with standardization, which I agree, it's unlikely that you'll get a test that's 100% accurate, 100%.
But it would avoid a tremendous amount of confusion.
I'd like to address that issue also. Lyme disease is in fact a bit more difficult to diagnose reliably than some of the other diseases. Dr. Barber certainly mentioned some of the problems with cross-reactivity in serum. As a spirochete, one of the major cross-reactivities, which is a P41 antigen, which is present in many patients that we see. So it's difficult to design an assay that will characteristically rule out any kind of cross-reactive samples. Another problem with direct assays is that there's very low levels of the spirochete present in biological specimens, and any assay that is designed would need to be able to be subject to a sampling question. There's presence of inhibitors, there's other kinds of complications which make it difficult to design an assay which is absolutely foolproof. One other concern is that there may be cyclic expression of both the antibody levels and certainly the expression of the antigen or the Borrelia itself, which may be reactivated during various times, so that a single test at a single time may miss the spirochete, whereas over time you might be able to get a better success. So I think it's a difficult agent to diagnose.
We have a question for Dr. McDonald regarding a patient with Lyme disease. What is the risk if that lady gets pregnant? What would be the risk for the pregnancy and for the baby?
The risk is unknown, but we do have information that just from anecdotal studies, patients living in endemic areas, that the risk is probably low for transmission of the spirochete across the placenta to the baby. The risk is not zero. I did some studies in my previous life, and I published those studies, and then I left the arena, and nobody else expressed interest in continuing that work. So the word on the street now is that probably the work that I did in the earlier years is not reproducible, and I don't believe that until we have another body of people or another institution that we can dismiss the results of my studies and also Dr. Paul DeRay's studies in the 80s as being not reproducible. We just don't have an opportunity to test it. There are cases that I believe are cases of adverse fetal outcome due to placental transmission of the spirochete, and those adverse outcomes include stillbirth, congenital malformation, neonatal fetal demise, and I think the ultimate tragedy is a baby that is born with sequelae of the infection acquired in utero that suffers with those sequelae in the first few years of life. The risk, though, I think for the vast majority of people who are pregnant and who have a tick bite is very low. I think that the risk for a person who has disseminated disease such as multifocal ECM is significant, and my view is that penicillin should be administered to those patients as if the patient had congenital syphilis to cover for or to forestall the possibility that the fetus will be involved, because remember, you're treating not just the mother, you're treating the fetus, and one of the reasons for mandatory testing for syphilis is to identify cases in pregnant women and treat those so that we don't have recrudescence of congenital syphilis in the 90s. Unfortunately, syphilis is forgotten but not gone. You know, when they eulogize people, they say gone but not forgotten. Well, syphilis is forgotten but not gone. And I think that it is important to treat patients who have a clinical profile of possible disseminated disease as if they had a risk factor for congenital syphilis, and that is to give them antibiotic coverage. It certainly won't harm the mother, won't harm the baby, and it probably could do some good.
We have some questions perhaps Dr. McDonald and maybe Dr. Coyle could address about the ocular events in Lyme disease. Can there be pigmentation of the cornea, glaucoma? What are the reasons for the visual disturbances commonly referred to as floaters, and are they related to the Lyme infection?
Well, floaters have nothing to do with Lyme disease. They're a benign phenomenon that really relate to sort of crystals that form. It's a benign finding that becomes more common with aging. The eye is recognized as a target in Lyme disease, not as common as some of the others. In the early stages, conjunctivitis, I think, was the most common ocular feature seen, and patients can have things like photophobia associated with it. And in later stages, there have been some fairly well-documented, it's not a common feature, fairly well-documented cases of uveitis and keratitis involving the eye. And then there have been some very unusual associations with perhaps possible associations with Lyme disease and retinal vasculitis and ischemic changes and optic neuropathy. So that the eye is recognized as a target. There are common syndromes of early dissemination and late dissemination, but it's certainly much less frequently involved than the nervous system, for example, or the joint system, for example, or even the cardiac system.
We have a question for Dr. Fallon. Our question is, are there any psychiatric manifestations of Lyme disease beyond the attention deficit disorder that was mentioned earlier this evening? So we have to organize our questions based on sides of the room, I suppose.
The most common findings in later stage Lyme disease would be things like memory problems, Typically, patients describe themselves as being in a Lyme fog, or they have word-finding problems. Sometimes they have topographic disorientation, where they go someplace and they suddenly don't know why they're there or how they got there or where they are. So those are memory-type problems. There are attentional-type problems, and then there are more psychiatric-type problems, and they can occur actually at any time during the course of the illness. Sometimes people may present actually with really marked anxiety that looks like panic disorder, and if it gets recognized as Lyme disease and tested positive for Lyme disease perhaps and treated, oftentimes the anxiety may go away without psychiatric treatment. Major depression is often commonly seen with patients with later stage illness as well. In a series that we looked at of 193 patients who responded to a questionnaire, about 70% of those patients reported symptoms that looked pretty clearly like a major depression. And about a third of them had suicidal feelings and thoughts during their illness. So depression, and particularly agitated depression, irritability, personality-like changes are not uncommon. Rarely you may see psychotic symptoms where a person becomes quite paranoid or becomes manic. Mood swings are not that uncommon, but frank psychotic symptoms can occur, but they're more rare.
Before we move on to the next topic, which would be treatment, do we have any questions otherwise from the floor on diagnosis or symptoms?
I have a few, just if someone can direct them. Have you seen where the neurological symptoms only affect one side of the body? Have included facial swelling of one side of the body, one side of the face? And also, is there a chance that if a person of extreme physical good condition, that their physical condition could hinder the diagnosis of Lyme disease?
Who's it coming to?
Well, sure, you can have neurologic involvement by a variety of processes, including Lyme disease, that might affect just one side of the body. And I think there have been cases of facial swelling that are almost a feature of facial neuropathy at times. And I think that you could also have some sort of swelling perhaps from as part of a skin manifestation. With regard to the question about could somebody who is in good health impair, I think that is a possibility because when you have an individual who has a lot of symptoms out of proportion to objective findings, then there may be the tendency to kind of be a little bit more dismissive for that individual. So yes, I think that could be a potential problem. But a good physician should really get past that.
May I ask one more question?
Go ahead.
With a Lyme titer, will you get an elevated Lyme titer if you are not infected with the Borrelia spirochete?
Yes, certainly there are patients who have antibody who are asymptomatic. If you go into any population, for instance on Long Island, you might find that as many as 7 to 8% of patients or individuals may have an antibody that would be considered to be positive. Whether that's due to cross-reacting antibodies, as was mentioned, due to the serologic test, or whether it's specific antibody is not really clearly known, but it is known that if you go to, there were studies that were done on forest workers who have a high level of exposure to Lyme disease, that those individuals can have very high levels of antibody, anti-Borrelia antibody that seems to be that meet all the criteria for having been infected with Lyme disease and not have any evidence of symptomatic evidence of Lyme disease, and seem to be that they were infected but have fought off the infection by themselves.
Thank you very much.
We have done a survey of about 1,503 people who just came to the syphilis department, to the STD clinic. When we did the Lyme borreliosis study on them, we did IFA, EIA, and Western blot. We had very high IFA as well as EIA in 35 patients. When we did the Western blot, we found very strong 41 kilodalton and very strong 66, which is a heat shock protein. And so Western blot wise, it is negative. We had one person who was also syphilis positive. We decided to do RPR and FTABS positive in both. So this cross-reaction happens quite often.
I have to announce that we have just 5 minutes left, so I want to encourage the audience and the respondents to be very brief, because I do want to touch on many other topics regarding treatment too. Question from the center.
Yeah, I'm probably one of the unreported Lyme cases in BC. I was treated 4 years ago for it, and I know it was never reported, but in any event, after undergoing weeks of agonizing joint pains, I was lucky enough to find a doctor who discovered the right numbers and gave me cortisone treatment. Well, first of all, ceftriaxone, eventually leading to cortisone treatment. Since then, I've undergone numerous weird symptoms, including I've had 2 pleuroscopies to remove liters of fluid in my chest that keep building up. And I wondered if anybody else has ever heard of this symptom or if it might be a manifestation of something else.
I believe Dr. Ligna presented a case earlier this evening where his patient had fluid around both lungs and the heart, which was coincident with the Lyme infection. Dr. Ligna, do you want to comment?